All right. Well, Chapter 27, Renal and Urogenital Disorders, is a repeat. I'm sorry, I have no idea why there was no volume. I know that GoToMeeting has changed its platform, and perhaps I didn't have something turned on, so I'm going to redo the lecture and then do the talks right after that, so that we can get caught up. So Chapter 27 dealt with renal and urogenital disorders, and we're going to be talking about the anatomy of the urinary system, beginning with the kidneys. And the kidneys are located on either side of the spine, between the 12th thoracic vertebrae and the 3rd lumbar vertebrae. The right is a little lower than the left to make room for the liver, and they're wedged between the back muscles and the peritoneum in this space called the retroperitoneal space. They're a bean-shaped organ with the adrenal glands sitting on top of them. And the kidneys are quite complex. They're made up of a vast system of tubules and blood vessels and those sort of things. The proximal convoluted tubule reabsorbs water, reabsorbs sodium, potassium, organic nutrients, that sort of things. When the body senses a need to retain water or retain potassium or sodium, that's done in the proximal convoluted tubule. The loop of Henle also reabsorbs water and reabsorbs sodium and chloride. And Lasix is a loop diuretic, so it works in the loop of Henle. The distal convoluted tubule secretes ions, acids, drugs, and toxins. And the collecting tubule reabsorbs water, but also secretes sodium, potassium, hydrogen, and bicarbonate ions in order to maintain your electrolyte balance as well as maintain your acid-base balance. And here's just a picture of the location of the kidneys as well as their complex makeup. The medial indentation is where the blood supply and the nerves enter and leave the kidney. The renal cortex is the outer layer where production of urine begins. The renal medulla is the cone-shaped cone-shaped renal pyramids, and the renal pelvis is where all the urine is collected. Nephrons, nephr refers to kidney, so nephrons, they're the functioning cell of the kidney or the functioning units of the kidney, and they filter the blood. They collect excreted water and waste products. They also reabsorb water and nutrients and electrolytes when necessary. The glomerulus interconnects with the capillaries and reabsorbs useful organic materials. 90% of all your water comes from being reabsorbed and filtrated through there. In order to determine whether or not the kidneys are working well, they often will measure the amount of urine output or the amount of urine produced per hour. And the normal urine output is about 30 mils per hour. Now, obviously, if you have more liquid in, your kidneys are going to work harder if you're overhydrated to eliminate more of that liquid, or if you take a medication like Lasix or Bumix, you're going to produce large amounts of urine in a short period of time. But as a general rule, your kidney function can be measured in part by the amount of urine that you secrete in an hour. So here's the example of the glomerulus and the tubules. A part of the kidney to include the loop of Henle, and you can match this, the proximal convoluted tubule and the distal convoluted tubules there, and as blood flows through here, these structures reabsorb water, absorb water, excrete water, reabsorb electrolytes, and like sodium, potassium, calcium, magnesium, all those things. As I mentioned, the nephrons reabsorb water, nutrients, and electrolytes, And the amount of urine you produce, of course, is dependent upon your hydration state. The amount of blood flowing to the kidneys also has a great effect on how much urine you produce. I know that in periods of shock where there isn't a lot of blood flow to the kidneys, that's one thing they can use to measure the severity of the shock is, how much urine output is there. Medications, of course, as I had mentioned, diuretics help you make lots of urine, but medications like narcotics have a tendency, or sedatives have a tendency to decrease your need to urinate. Your bladder continues to fill, but being able to urinate becomes a major problem on some of those medications. And then your hormone levels affect the urine production as well. To get rid of water is known as diuresis. So we diurese all the time, and again, we may need to take medications depending on our individual situations to help our kidneys excrete water. But remember, sodium follows water and potassium follows sodium. Oftentimes when you're making large amounts of urine because of a drug like Lasix, those are non-potassium sparing diuretics, and one of the effects of diuresis, especially excess urine production, is the loss of potassium. So here's the blood supply that matches the structure of the kidney, and I think there's another one here where it puts both of them together, so you can see the blood supply and then the intricate tubules within the kidneys that selectively reabsorb or excrete water and electrolytes. And there is the process of urine formation in great detail, and where the reabsorption and secretion of some of these things occur, as we'd already mentioned. ADH refers to the antidiuretic hormone, and vasopressin is actually an antidiuretic hormone that your body produces naturally when sensors, baroreceptors, since the volume is depleted, they will decrease the blood supply by causing vasoconstriction to the kidneys, which will decrease blood supply and decrease urine formation, and thereby conserve water so that you don't become dehydrated. Ureters and the urinary bladder. Ureters are thin-walled microscopic tubes where urine is drained through a process, as we know, peristalsis. It's the same process that propels food down your esophagus into your stomach and food through your whole GI tract. That same wave-like muscular contraction also helps urine drain from the kidneys into the bladder. The bladder is where the urine is stored before elimination, and both males and females have bladders. But I think what's important here might be the size of the bladder, as well as the location of the bladder, and how that may change somewhat in females, particularly in their third trimester of pregnancy. And then here is just a example of a female urinary bladder and where it is located there behind the pubis symphysis, and the male's bladder as well, but it takes on quite a different shape than the female bladder. The urethra is a short tube that transports the urine from the bladder to outside the body. It passes through a band of skeletal muscle, and the external urethral sphincter helps control the flow of urine. When that relaxes upon the sensation that your bladder is full, that relaxes, and urine is allowed to drain out of the bladder as the bladder itself contracts. A excretion must match intake in order for homeostasis to remain normal, and the kidneys alter the filtration excretion rates to match the body's intake. So the more I take in, the more the kidneys are going to excrete. The less I take in, the more the kidneys are going to retain. So the kidneys do a good job in helping us stay hydrated. We can't talk about the kidneys without mentioning the renin-angiotensin system, which is the RAAS system. Kidneys convert a protein that's already in blood to renin. Renin converts to angiotensin, which is released by the liver, and the renin converts the angiotensin released by the liver to angiotensin 1. Angiotensin 1 converts to angiotensin 2 in the lungs, and angiotensin 2 is a very potent vasoconstrictor, which increases the blood pressure. So in people, medications that may be taken to help lower blood pressure by causing vasodilation would be ACE inhibitors. ACE stands for angiotensin converting enzyme inhibitor. And ARB is known as, those are your angiotensin renin blockers, a newer generation of drug used to treat blood pressure. ACE inhibitors are your pril drugs, with lisinopril probably being the most common ACE inhibitor, and ARBs. Diovan is certainly a trade name of one of the newer ARBs. The thing about these drugs is they work great in diabetics because they do cause the vessels to dilate somewhat when taken, because the angiotensin 2 is not produced. And by dilating the blood vessels, your kidneys actually get a better blood flow, which is good in patients with diabetes. So if you have a diabetic patient who's hypertensive, you'll often find them on either an ACE inhibitor or an ARB. Aldosterone regulates blood pressure in the distal tubules of the nephron. Aldosterone causes an increased reabsorption of water and the conservation of sodium and secretion of potassium. So by reabsorbing water and retaining sodium, volume is expanded and the blood pressure is maintained. And this is just a visual of that, where the blood converts angiotensin secreted by the liver combines with renin secreted by the kidneys to form angiotensin 1. And then the angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. And angiotensin 2 causes vasoconstriction and high blood pressure. So by not allowing angiotensin 2 to be produced, the blood vessels dilate and the pressure drops in the system. The kidneys are very important in helping regulate acid-base balance by excreting acids and regulating your body stores of buffers. And here they're referring to the excretion of hydrogen and the retention of bicarbonate. So your body will secrete hydrogen when necessary and try to retain bicarbonate to help you with acid-base balance. The kidneys don't act quickly in the regulation of the acid-base balance system. You'd expect the kidneys to function and help regulate the acid-base system over a period of days, where we have other buffer systems that work almost instantaneously. The kidneys are rather slow, but do help by secreting hydrogen ions and retaining bicarbonate. The urinary system also excretes waste products and foreign chemicals. It's the kidney's responsibility to eliminate waste products generated by metabolism, including urea and creatinine, as well as uric acid and bilirubin. And that's another way, certainly, of telling kidney function. In addition to urine production, they'll look at your BUN and creatinine. So by looking at your BUN and your creatinine, if those numbers are out of whack, they know that your kidneys aren't functioning properly as well. Kidneys also eliminate toxins. They eliminate food additives that your body's unable to digest, as well as medications that that are not um, properly metabolized or used. The urinary system also is responsible for the secretion of certain hormones. One of those hormones is erythropoietin, and erythropoietin increases red blood cell production. So in a way, your kidneys are responsible for, or your urinary system is responsible for, an increase in red blood cell production. Calcitrol, which is an active form of vitamin D, helps mobilize calcium from the bones to the blood, so that if your calcium level dips low in your blood, you can rob some of that from your bones. We know that calcium as well as sodium and potassium are extremely important to the overall function of your heart. Renin is formed in the kidneys, and again, it initiates the formation of angiotensin II. Because the kidneys are somewhat responsible for red cell production during renal failure or with other kidney diseases, erythropoietin may not be secreted, which can lead to severe anemia. And gluconeogenesis, during a situation where there's prolonged fasting, the kidneys will try to make new glucose from things like amino acids and other chemicals. Excuse me. As far as your general assessment goes for renal and genitourinary issues, during your detailed physical exam, you want to get a recent medical history or a sample history, history of the patient's chief complaint, and you want to look into if their chief complaint involves anything with not being able to urinate, a change in bowel or bladder control, or bowel and bladder habits. Then you want to ask additional questions like, do they have an increase or decrease in urinary frequency? Do they have pain or burning with their urination? Is there any unusual color or odor to the urine? Is there blood in the urine? Is there any unusual discharges as well? These we just mentioned as part of your physical exam. Are there any unusual lumps or recent swelling, particularly with men in their testicles, which might indicate either testicular cancer or even things like a hydrocele? Evaluate the presenting pain with OPQRST like we do any pain, and try to determine whether the pain is visceral or somatic. Remember that somatic pain is generally localized. It's usually sharp. It's the pain you might feel when you hit your thumb with a hammer. Where visceral pain is dull, kind of a pressure, is very diffuse across wide areas. It's hard to pinpoint, because that might give you an idea of what's causing the pain as well. You want to inspect the abdomen to see if it's distended, see if there are any scars or wounds on the abdomen, whether there's any pulsating masses in the abdomen. Do both sides look round and symmetrical? Listen to the abdomen with a stethoscope. You should be able to hear bowel sounds and gurgling somewhere between 5 and 35 times a minute. Hypoactive bowel sounds, that's when you don't hear them less than 5 times a minute, and hyperactive bowel sounds would be heard more than 35 times a minute. The absence of bowel sounds certainly could indicate either an ileus or a bowel obstruction. You want to palpate the abdomen, note skin temperature and moisture. Again, when palpating the abdomen, you're looking for tenderness, swelling, and pulsations. Percussing the abdomen is not something we see done very often or very frequently. That's where you place the palm and fingers of a flattened hand over each abdominal quadrant, and then with 2 fingers of the other hand you tap on the index and middle fingers of the hand laying flat on the abdomen. You're listening for a thud or maybe a very hyper-resonant sound that you might hear when tapping on an empty kettle drum. to indicate the presence of fluid or air. When percussing the kidney, put the patient on the side that you're testing, place a flattened hand over the kidney, and with the fist of the other hand strike the flattened hand, and see what sort of response that you get. If percussion leads to the presence of an acute urologic emergency, we manage that with primarily being supportive. IVO2 monitor. If they're in a lot of pain, like if they have a polynephritis, an inflammation of the kidney itself, or a nephritis, then they may be in enough pain to require some sort of pain medication, and then frequent vital signs while transporting. There are some diseases of the kidney that we should be aware of. We'll look at first probably the most severe one, which is acute renal failure. And this is when the kidneys just suddenly stop working. It may be the result of a major insult to the body, like a major trauma, where there's a significant blood loss or shock. And if in shock long enough, we know that during shock your blood vessels constrict to pump blood to all your vital organs. Well, whenever that occurs, usually your vital organs receive a blood supply at the expense of the gut and the kidneys. So they often get low blood flow states during shock, and as a result can have significant cellular tissue damage, and may go into acute renal failure days after the insult. It can be reversible depending on how soon it's caught. Again, causes might include shock and abnormalities within the kidney itself, or a blockage of the urine system by a stone. It should be resolved quickly in order for it to be reversible. Also, with acute renal failure, you have pre-renal acute renal failure, and that's due to the result of a reduction of blood supply to the kidneys. That's the most common cause, with hypovolemia from blood loss being the cause of this pre-renal acute renal failure. It can also be caused by cardiac problems or abnormalities in the kidney hemodynamics, or hypotension caused by vasodilation as well. Interrenal acute renal failure develops within the kidneys themselves, and this may occur from the small blood vessels, or a glomerulus injury, or tubule structural injury, or interstitial kidney injury from something like an acute pyelonephritis. Intrarenal acute failure assessment. Because the injury or the failure occurs inside the kidney, and the kidney isn't working properly, you might see things like bleeding in the urine, or blood in the urine, uncontrolled hypertension, perhaps a recent history of hypotension after hemorrhage, drug overdose, or abuse, sepsis, surgery, cardiac arrest, toxin exposure, new medications, recent blood transfusion, and other things that may cause the intrarenal acute failure include exposure to things like heavy metals, particularly mercury, arsenic, and lead, solvents, hydrocarbon solvents, methanol, theophylline, glycol, antibiotics, angiotensin converting enzyme inhibitors, antidepressants, anticonvulsants, analgesics, and non-steroidal anti-inflammatories, anti-cancer drugs, pesticides and herbicides, and drugs that can form methemoglobin, because methemoglobin doesn't transport oxygen. With post-renal acute renal failure, it's due to the result of a block of flow of urine, and it's usually only one kidney is affected, but then expect the other kidney to have to increase the workload if that one kidney is in failure. And that has something, like as mentioned before, if this acute renal failure is managed within the first couple hours, then you have better outcomes. Okay, trying to move on to the next slide here. Not sure why it's hung up, but next slide. There we go. With acute renal failure, get a history and physical exam as far as findings. Azotemia is nitrogen-containing waste product buildup. It leads to metabolic acidosis and hyperkalemia. One thing that you will smell, particularly in acute renal failure, in addition to you can smell urine, but you also can, if the kidneys fail, you can get a very distinct odor of ammonia coming off the patient as well. Some other history and physical findings on exam for somebody in acute renal failure include decreased or absent urine output, and that would have to be something the patient told you, or something you observed if you're caring for a patient on a very long transport or in a hospital. Increased urination at night, swelling of the feet, ankles, and legs, neuropathies of the hands and legs, in other words, the numbness, pain, tingling in the arms and legs, anorexia, altered mental status, seizures, metabolic taste in the mouth, hand tremors, bruise easy, prolonged bleeding, flank pain, ringing in the ears, and certainly high blood pressure. As part of your history and physical exam, you want to get a good medical history. Some questions you might also include would be, if they ever had any kidney stones, do they have any history of prostate enlargement, have they suffered from gout, and some medications used will cause crystal formation. I'm not sure if they're referring to mannitol. Mannitol is an osmotic diuretic that may help the patient diurese, and I know depending on particular temperatures that the mannitol will crystallize and turn into little white floating crystals. Therapeutic interventions for somebody in acute renal failure, ABCs, IV access, vital signs, treat for shock. So there's not much we can do other than be supportive. If they've ingested a toxin, then treat them for their ingestion by calling poison control. Transport, if that's what's advised. Prevention is going to go a long ways in correcting the pathology leading to acute renal failure. So if the patient has hypovolemia, making sure that we restore their blood pressure to an adequate map that would perfuse the vital organs. Treat any toxic exposure to reverse the effects of the toxin. Severe cardiac disease will lead to stress on the renal system and could lead to renal failure. Patients with acute renal failure may develop orthopnea. They're unable to breathe lying flat, or they may get PNDSP, which is paroxysmal nocturnal dyspnea, and the paroxysmal nocturnal dyspnea is a shortness of breath that comes on suddenly at night. So this patient might be propped up on pillows, doing fine, and then all of a sudden wakes up unable to breathe and ends up calling 911. So that might be an indication of acute renal failure as well. Chronic renal failure is a structural and functional abnormality of the kidneys that's been present for 3 or more months. It's usually irreversible loss of nephrons that cause this. Nephrons are the cells of the kidney, and if those are lost, the function of the organ goes down to the point where they can eventually fail. Chronic renal failure will progress into end-stage renal disease. Causes of chronic renal failure include glomerulonephritis, polyarteritis nodosa, lupus erythematosus, diabetes mellitus, hypertension, atherosclerosis, toxins, renal calculi, prostate enlargement, constriction of the urethra, and polycystic diseases. All of these could cause chronic renal failure. Those at risk of chronic renal failure include diabetes and hypertension being the two top risks. Somebody with high cholesterol, somebody with an autoimmune disease, somebody with a chronic systemic infection, somebody with urinary tract infections, somebody with urinary tract obstructions are all at great risk of chronic renal failure. Cancers, chronic kidney disease, and a family history of chronic renal failure. Reduced renal mass, low birth weights, drug overdoses, particularly Tylenol. And then recovery after acute renal failure. The damage may be severe enough that it leads to chronic renal failure. Chronic renal failure leads to uremia, or a buildup of toxins in the blood. And the signs and symptoms include a headache, weakness, mental status changes, loss of appetite, nausea, vomiting, diarrhea, weight loss, increased urination, rusty brown colored urine, increased thirst, hypertension, puffiness around the eyes, uremic frost, and itching. Some therapeutic interventions for chronic renal failure is to get the kidneys working better, but we really don't have anything other than Lasix, and in these patients it's not wise to give them that. So airway, breathing, circulation, IV access, vital signs, trending the vital signs, and transport. What a person needs with chronic renal failure would be things like hemodialysis, and then either home dialysis or peritoneal dialysis at home, kidney transplant, and diet monitoring. Causes of functional nephron loss include diabetes and hypertension are the two most common causes of end-stage renal disease. And diabetes has a lot to do with chronic working of the kidneys, particularly with high blood sugars, and hypertension is just the organ is just overworking and eventually fails. Glomerulonephritis, polycystic kidney disease as well. Signs and symptoms of end-stage renal disease include confusion, decreased level of consciousness as the ammonia continues to build up and up in the bloodstream, making the patient extremely acidic, decreased level of consciousness, shortness of breath, peripheral edema, chest pain, bone pain, sweating, nausea, vomiting, diarrhea, anemia, easy bruising, muscle twitching, anxiety, delirium. In fact, delirium in the elderly, the number one cause of delirium in the elderly is end-stage renal failure or urinary tract infection. Hallucinations and seizures. Therapeutic interventions. These patients need hemodialysis or peritoneal dialysis. If it's done emergent, you'd have to take them to a facility that could do emergent dialysis, or peritoneal dialysis can be done at home. Dialysis diffuses blood across a semi-permeable membrane, and in doing so removes substances that the kidney normally would get rid of, and they can do dialysis until the patient is able to receive a kidney transplant or they can be on hemodialysis or peritoneal dialysis. So kidney transplant or continued hemodialysis or continued peritoneal dialysis. For end-stage renal disease, the therapeutic interventions, if a person is on dialysis, they're going to have an AV shunt, usually in their forearm. It makes the vessel very large and easy to stand out, and as a result, they're just not a candidate, regardless of their blood pressure or other situation, to stick that AV shunt. So don't take a blood pressure on that side. Don't apply firm direct pressure on that arm. Don't start an IV on that arm. Loosen tight restrictive clothing on that arm. And here's just a visual of both hemodialysis and then peritoneal dialysis. Up top you have the inflow and outflow coming out of the shunt in the arm and going into an artificial kidney where the dialysis takes place, and then the blood is pumped back into the body, where with peritoneal lavage, and that can be done on some diabetics in their home. With peritoneal lavage, a special liquid is drained into the abdomen, fills the abdominal cavity, where it then is strained through a permeable membrane into a collection container to be thrown away. And it does a very similar job in cleaning out the blood. Some complications of dialysis include hypotension, particularly if they take the blood off too fast, muscle cramps, nausea, vomiting, disequilibrium syndrome, hemorrhage from the shunt, air embolism, and chest pain. Bleeding at the catheter site can also be a problem. Fluid overload, and the signs and symptoms of a fluid overload include the development of acute pulmonary edema, development of high blood pressure, elevated potassium level, which we would see on the 12-lead ECG as peak T waves, and then uremic frost. Hyperkalemia is a complication of dialysis, more so a complication of skipping dialysis. When a person doesn't get to dialysis on time, remember, their kidneys haven't been working at all. So if they've gone 3 days without dialysis and they've taken in a lot of fluids, very few of those fluids have left their body. I have a cousin who is on, or was at one time before his kidney transplant, was on dialysis. And it was not uncommon for them to pull 10 or 15 pounds of water out of his system every 3 days when he went into dialysis. So if they skip their dialysis, hyperkalemia is certainly a sign and symptom that we might see as a result of skipping their dialysis, which may lead to a slow, irregular pulse, muscle weakness, hands, feet, and tongue tingling, ECG changes starting with depressed P waves, widened QRS complex, peak T waves, and then uremic frost. Therapeutic interventions, ABCs, if they have severe hyperkalemia, they could arrest, so do keep that in mind. You may have to intubate them and assist their ventilations. Establish IO access, and look for medications that you might use with somebody in hyperkalemia, to include calcium chloride, glucose, and insulin, and continuous albuterol nebs. Renal calculi. Renal calculi are kidney stones, and they occur more frequently in men. The urine becomes highly concentrated with calcium salts, uric acid, and crystine. It's also the result, it results in renal blood flow alteration as well. There are four main types of kidney stones. There's the calcium-containing stones, which make up the majority. Nearly 75% of all stones are calcium-containing stones. There are uric acid stones, and they make up about 10%. And there are crystine, or struvite, infected stones, and these make up about 10% of the stones and form after an infection in the urinary tract, and then cystine stones, and these are stones that form from the amino acid cysteine, which is the most uncommon type of stone. So calcium is going to be your most common stone. And here's just an example of different types of kidney stones. Bladder stones, calcium, uric acid stone. Okay. All right. The epidemiology and etiology of kidney stones might be the result of a renal infection like a polynephritis or an abscess or even sepsis. Increases the risk of these an increase in the formation of kidney stones. Ureter blockage also can occur from the stone being too large to pass. If the stone is less than 5 millimeters, it should pass spontaneously within 4 weeks. If the stone is greater than 8 millimeters, it may require surgery or lithotripsy in order to break the stone up so that it can pass. Get a good history and physical exam on this person that you believe is having a kidney stone. If they have a history of kidney stones in their family, if they lead a sedentary lifestyle, if they suffer from Crohn's disease or hyperparathyroidism, if they give you a history of frequent urinary tract infections. If they live in a hot and dry climate, and I think that has to do with dehydrating, folks. And then if they have, again, a prior history of renal calculi formation of their own, let alone their family history. Some history and physical exam findings with kidney stones also include some risk factors. The more red meat you eat, the more calcium you take in. Your state of hydration, if you're slightly dehydrated, you run a greater risk of forming these stones. The amount of oxalate you have in your blood, as well as sodium. And people on extreme diets that have extreme shifts in their ion balances may be more at risk of developing kidney stones. Signs and symptoms of a kidney stone, anybody that has one knows they're extremely painful. They may start in the back at the flank in that retroperitoneal area. The pain may radiate around the flank into the groin and genitals. May also cause abdominal pain, nausea and vomiting. The urination may be more frequent but in smaller amounts. The urination may be painful, as it may cause the stone to move as they urinate. They may have blood in their urine depending upon the size of the stone, and they may also have fever and chills. For treating patients with urinary calculi, ABCs, IVO2 monitor, certainly if they're in a great deal of discomfort or pain, we could give them a narcotic analgesic or some sort of non-steroidal anti-inflammatory drug. And antiemetics if they're throwing up, and put them in the position of comfort, which may be difficult if they're in severe pain. Urinary retention is another problem associated with the urinary system, and this is when a person's unable to completely empty their bladder when they urinate. This occurs more frequently as you get older. And they'll have moderate to severe lower urinary tract symptoms, as if they've got a urinary tract infection. It may be caused by benign prostatic hypertrophy or an enlarged prostate gland, and then specific drug therapies may make it more difficult to urinate. It doesn't mean that you're not producing urine. It just means that you're not able to work those muscles to help you secrete the urine. And we see this in patients taking narcotic pain pills. Your hydrocodone, your oxycodone, all those sort of things. Causes of urinary retention include urinary bladder muscle fatigue, nerve damage, urethral blockage, enlarged prostate gland, Some of the history and physical exam findings that you'll find is this person will complain of a sudden inability to urinate. Their bladder will be extremely distended and painful. And in the elderly, they may be delirious. Some therapeutic intervention, of course, is to get them to the hospital where they can drain that bladder. For us, it's since we don't do Foley catheters anymore or quick caths anymore in the field, is primarily supportive. Put them in a position of comfort, IVO2 monitor, give them something for their discomfort as far as pain goes, and then they need to be cathed. Urinary system infections like cystitis, polynephritis, they're more common in women, may be also the result of an E. coli, and gonorrhea and chlamydia are both urinary system infections as well. Go for a history and physical exam to know whether they have a urinary system infection. They might complain of burning pain during urination or increased urinary frequency, cloudy urine, rust-colored urine, foul-smelling urine, low-grade fever, and if left untreated, the cystitis will spread to the kidneys, causing a polynephritis. Polynephritis, you have flank or back pain, high temps, chills, flushed skin, sweaty, headache, urinary frequency, difficulty urinating, and maybe even blood in the urine. Therapeutic interventions for urinary system infections include prompt transport and certainly look for, and if not, treat for septicemia or look for signs of septic shock, which in this case would be tachypnea, tachycardia, and an elevated temperature. Urinary system conditions are those urinary system conditions limited to males include issues with the male genitourinary structures, starting first with the penis. The penis is made up of a root, a body, a glans penis or the head. The root connects to the pelvis by ligaments. The body is two cylinders side by side. The corpus cavernosa, and they fill with blood, causing the penis to be erect. And once the chamber or the corpus, one chamber or the corpus spongiosum surrounds the urethra and allows for elongation of the penis. Some other male genitourinary structures include the scrotum. Typically the left testicle is larger than the right because the spermatic cord is on the left and it's a little longer. The scrotum itself is quite vascular, so when nicked or cut, it does have a tendency to bleed heavily. It does contract and expand and contains the testes. The testes are suspended by the spermatic cords. They produce sperm and testosterone in men. They have a large amount of blood vessels and nerve endings to them as well, so can be extremely painful when injured. Sperm production occurs in the epididymis with about 18 to 20 feet of tubes used to store the sperm. Sperm is transported to the vas deferens. They arrive at the seminal vesicle next to the urinary bladder, where it is stored for ejaculation. And here's just a picture of all of that we just talked about, the male genitourinary structures, including the bladder, the urethra, the penis, and the testicles. Genital lesions that occur in males could be genital herpes, could be syphilis, could be chancroid lesions, granuloma inguinal, lymphedema, genital warts, molluscum contagiosum, not sure what that is, but it sounds like it's contagious, and allergic reactions can cause swelling or lesions on the genitals as well. Blunt trauma to the genitals. Signs and symptoms of that certainly would be swelling of the scrotum. Remember that it's very vascular, and a blow to that area could cause some severe, significant hemorrhage into the scrotum, filling it full of blood, Oftentimes, filling it full of blood, the scrotum will expand to a point where there's a great deal of pressure on the contents in the scrotum, which may help tamponade the bleed. Signs and symptoms of blunt trauma, of course, to the genitals would include swelling of the scrotum, severe pain, peritonitis, and if the blow to that area is significant enough, there could be also a pelvic injury or a spinal cord injury. Therapeutic interventions for urinary system conditions limited to males include ABCs, IV fluids, cold compresses to the groin. If they're in a great deal of pain, certainly analgesics. If you're thinking pelvic fracture, then stabilization of the pelvis. If you're thinking spinal cord fracture, then certainly immobilization of the spine. Fournier's gangrene is another genitourinary infection limited to males. It's a bacterial infection of the genitals. You may see something like skin crepitus, gray-black discolored tissues, pus draining from the tissues, and a high temp. Signs and symptoms of the genitourinary infection called Fournier's gangrene: genital pain and redness, odor from the discharge, severe genital pain, swelling of the penis, the scrotum. If left untreated, certainly this infection can spread to the blood, causing septicemia, heart failure, and death. So prompt transport is necessary, and those people at greater risk of developing Fournier's gangrene include those with diabetes, alcoholism, advanced in age, poor nutrition, and steroids. Prostatitis is a inflammation of the prostate gland. Urethritis is an inflammation of the urethra, and these can be caused from a variety of reasons, but when those structures become inflamed, they certainly become painful, and with urethritis, men and males may have trouble urinating because of the burning in urination. Phimosis and paraphimosis are structural conditions seen in men, and that's in men who are not circumcised. It's the result of the inability to retract the foreskin over the penis glands or the head of the penis. As a result, you can develop a tight ring around the head, which acts as sort of a tourniquet, causing the head of the penis to swell. If you're unable to retract the foreskin over the head of the penis, then an infection can occur under the foreskin, which may lead to some sort of pussy discharge out of that foreskin. And here's just something to try to show you some sort of visualization of the uncircumcised male with the foreskin over the glands and forming a tight ring around the base of the glands or the head of the penis, which can lead to an infection. One condition that a person can do, I would imagine it would be painful, would be to certainly squeeze the head of the penis firmly for 10 minutes to help reduce swelling in that particular area. Wrap the penis in gauze, apply elastic wrap to the distal end of the penis to produce a constant gentle compression and transport. Priapism is a prolonged painful erection that can be caused by blood disorders. It can be caused by accidental surgical trauma, particularly in patients having prostate surgery. It can be caused by nervous system damage from multiple sclerosis or from diabetes. Erectile dysfunction drugs can lead to priapism as well. Drugs injected into the base of the penis to enhance sexual performance, and those would be things like methamphetamine. Psychotropic medications may cause an erection, as well as that spine trauma, which we've all been taught to look for priapism in a person that we suspect has a spinal cord injury. Benign prostatic hypertrophy is a non-cancerous enlargement of the prostate gland, puts pressure on the urethra, restricts the flow of urine, and some complications, of course, would include urinary retention, frequent urinary tract infections, the development of renal colic, and the obstruction would lead to a backup of urine, which could lead to renal failure. Testicular masses could be painless lumps on the testicle, or there may be pain in the scrotum. Emergent testicular masses could be the result of testicular torsion, or a strangulated hernia, or an actual testicular cancer, malignant cancer. Some benign causes of testicular masses include hydroceles, variceles, and spermatoceles. Testicular torsion, the spermatic cord is twisted inside the scrotum, sudden onset of severe pain in one testicle. There may be some sort of predisposing event like trauma, swelling on one side of the scrotum, a lump on the testes, blood in the semen, nausea and vomiting, and lightheadedness. All right, so that ends our discussion on renal and genitourinary. It talked primarily there in the end about urinary conditions seen commonly in males, and I'm going to guess that they didn't go into great detail on females because they will pick that up in the OBGYN part of the course. So any questions, you know how to get a hold of me. Thanks, and we'll talk to you soon.